pregnancy. And also, secondly, to understand the pathogenesis and also the pathophysiology of this hypertension in pregnancy. And lastly, to discuss the management of hypertension in pregnancy. And so our outline will be as follows. You can go to the next one. We introduce the topic. We'll classify the disease, the hypertensive disorders, and we will now talk about the two most common conditions, the common hypertensive disorders in pregnancy, which are preeclampsia and eclampsia. And then we'll look at the risk factors, the pathogenesis, the pathophysiology, investigations, the treatment, and we'll see the references. Yeah. So as we begin this topic, I want us to know that hypertension is one of the common conditions that you will find in pregnancy. Yeah, about 10% of pregnant women will experience hypertension. So in as much as it's common, it's also a very dangerous or, yes, a dangerous disease such that it needs treatment. Yeah, and that is why we'll be looking at it today. You can go to the second slide, the next slide. Yeah, so in our introduction, we just define what hypertension is. And this is a condition where the blood pressure is equal to or above 140/90 millimeters of mercury. Or it can be a rise in the systolic blood pressure of about 30 millimeters of mercury or more, or a rise in the diastolic blood pressure of about 15 millimeters of mercury or more than the previously known blood pressure of that particular patient that you are seeing. Yeah, so this blood pressure reading should be this much or higher in 2 readings within 24 hours, which should not be less than 6 hours apart. Yeah. So just to classify the condition, we can go to the next slide. The hypertensive disorders that we get to see in pregnancy are the following. We can have gestational hypertension. So this hypertension will occur in pregnancy and be noticed after 20 weeks of gestation without any proteinuria. So we find hypertension to be a blood pressure of over 140/90 millimeters of mercury. It should be higher or equal to, for the first time in pregnancy, the patient has never presented with hypertension before, and this should be at a gestational age, which is greater than 20 weeks. Yeah, and then just to define proteinuria, since in gestational hypertension, we are not going to have any proteinuria. However, in preeclampsia, we're going to define this as it's a gestational hypertension as well as proteinuria present. So we have protein in urine, and this protein should be equal to or more than 0.3 grams per 24 hours of the specimen, or 0.1 gram per liter. And then, so when you're using a dipstick, it should be +1 of protein or more. So you're going to categorize that as preeclampsia, which is gestational hypertension with proteinuria in it. And then eclampsia is just having preeclampsia with convulsions and a coma. So the patient can be convulsing and can also be in coma, or just convulsing, or just having a coma, but also has preeclampsia. And some patients have chronic hypertension. Chronic hypertension is where this hypertension will be detected before 20 weeks of gestational age, and then the patient would be maybe also a non-hypertensive. Yeah, and then we can also have superimposed preeclampsia or eclampsia, where the patient is a non-chronic hypertensive patient, and then they present with proteinuria in urine. So that will be superimposed preeclampsia. We can go to the next slide. Okay, yeah, so to talk about preeclampsia, so this is a disease that affects a multiple of systems in the body. So it's a multisystemic disorder of unknown etiology. So the cause is not known most of the time and is categorized by the development of the hypertension of about 140 millimeters of mercury, 140 over 90 millimeters of mercury or more with proteinuria, and that should be after 20th week of gestation. And this should be in a previously normotensive woman or a woman who does not have proteinuria or who's never presented with proteinuria. And as we continue discussing, I would like us to know that the normal blood pressure changes in pregnancy are that in the first trimester, there will be a decrease in the blood pressure. And as we go to around the 20th week, it's also low and may be the lowest recording of the blood pressure. And when we get to the third trimester of pregnancy, you find that the blood pressure actually returns to normal. Yeah, we can go on. Yeah, so preeclampsia can be classified into two, where we say there is mild preeclampsia as well as severe. So in mild preeclampsia, the blood pressure reading will be between 140 over 90 to 159 over 109 millimeters of mercury. And there'll be proteinuria, which is not so significant. It's going to be about +1 or +2 of the when you use the dipstick. Yeah, and then it's also going to be less than 5 grams 5 grams per 24 hours of urine if you're going to use that reading. Yeah, so for severe preeclampsia, there's a number of things. There are a number of things that you're going to look out for. And some of them are that there'll be a persistent systolic blood pressure of greater than or equal to 160 millimeters of mercury, or a diastolic blood pressure of greater than or equal to 110 millimeters of mercury. And then the excretion of protein in urine is going to be greater than 5 grams per 24 hours, or the dipstick reading is going to be 3+. And then the platelet count is going to be less than 100,000 millimeters cubed. And the patient can also present with HELP syndrome. And HELP syndrome, we're going to look at it as we look at the pathogenesis as well as the pathophysiology. The patient can also present with cerebral or visual disturbances, and this is where the convulsions and also the coma come in. The patient can also have persistent severe epigastric pain. We're going to understand how this comes about as we look at the pathogenesis as well as the pathophysiology. So the patient will also may present with retinal hemorrhages, exudates, or papilloedema. And they can be intrauterine growth restriction of the fetus because of the effects of this preeclampsia. And the patient can also present with pulmonary edema. Moving on. Yeah, so some of the immediate complications as we go into to discuss the next common condition is that when someone has got preeclampsia, there's a risk of it progressing to eclampsia if not treated, or maybe if it's not detected earlier. And so maternal complications may be eclampsia, hypovolemic shock. All of these we're going to understand as we look at the pathophysiology as well as the pathogenesis. So you find that there is dimness of vision and blindness. Those are the retinal effects of this disease. The cerebral hemorrhage, the preterm labor, postpartum hemorrhage. This is where one bleeds after they they deliver their baby, and then HELP syndrome, which we're going to understand, as I said, and then they can also be acute respiratory distress syndrome, and this may be due to the pulmonary edema that has come in due to the disease. The fetus will also have these complications, such as some of these. This is not like everything, but just some of them are that they can be intrauterine death, they can be intrauterine growth restriction, and then the fetus can also experience asphyxia and also prematurity due to the preterm labor that may occur. Moving on, so we're going to discuss eclampsia now, because we have seen that preeclampsia can actually progress to eclampsia. So preeclampsia, eclampsia is derived from a Greek word meaning like a flash of lightning. And this is because it may occur very fast without any warning. But it should be noticed that more than 80% of patients that may present with eclampsia may have already shown symptoms of preeclampsia. Yeah. And so eclampsia is where a patient has preeclampsia with convulsions. So the patient has got a blood pressure of greater than 140/90 millimeters of mercury, and also has proteinuria, which is greater than 0.3 grams per 24 hours in urine, and also presents with convulsions and a coma, or just convulsions or a coma. Yeah. So the incidence of eclampsia is about 25% during pregnancy, and then 50% during labor, and another 25% postpartum. Yeah. So we should note that this incident percentage or rate that has been shared because of the exposure that people may actually have. We can move on. Okay, so some of the risk factors that we see that cause this disease are that it's usually seen in a patient who is getting pregnant for the first time. Yeah, so these are young people, and also maternal age. So in the person that is getting pregnant for the very first time, it may be someone who's young or someone who's older, and then the maternal age also plays a role. So when someone, it's common in people who are less than 20 years, and also in people who are more than 35 years old. Yeah. And then another risk factor is family history. So if someone's relatives have had hypertension or preeclampsia before, it's a risk factor, so they should also look out for that. They might also have it. Placental abnormalities such as hyperplacentosis, where there's excessive exposure to chronic villi. So this is usually seen in molar pregnancy, teen pregnancy, and also diabetic patients. Yeah, and they can also be placental ischemia. So another risk factor is obesity, where someone will actually have a body mass index of greater than 35 kg per meter squared, and also insulin resistance, which falls under diabetes. Another thing is that when someone has a pre-existing vascular disease, you find that they may actually develop preeclampsia or eclampsia. Yeah. And then new paternity. This is where someone has a new husband, or is impregnated by someone else other than the person that impregnated her the first time. So the real cause, or what plays a role in this has not really been established, but it's been noted that women that have new paternity get to have preeclampsia or eclampsia. And also diseases such as thrombophilias. These disturb the coagulation cascade and whatnot. So you find that women who have these diseases are also predisposed to having these two conditions. We can move on. Yeah. So the pathogenesis of these hypertensive disorders is that the most important causes of these disorders are endothelial dysfunction and vasospasms. These come about. Okay, sorry about that. So yeah, these are the most common causes, and these are due to the pregnancy not following the normal progression. So you must realize that when one is pregnant, there are trophoblastic invasions that occur, and that occurs in the first trimester as well as in the second trimester. So you find that the trophoblastic invasion, the second one in the second trimester, does not occur. In the first trimester, it occurs between the 10th and the 12th week, where the endovascular trophoblast invade the uteroplacental bed up to the decidual segments. And then in the second trimester, another wave of the trophoblast invade up to the myometrial segments. But then what happens in preeclampsia or eclampsia is that the second invasion does not occur. And then when this does not occur, it causes the myometrial segment to be exposed to the vasoconstrictors in the body. We should realize that the placenta produces angiotensinase enzyme, which destroys angiotensin 2. And so when angiotensin 2 is destroyed, the vascular system synthesizes prostaglandin I1 and nitric oxide, which are vasodilators. And so when the invasion does not occur, the myometrial segment is exposed to the vasoconstrictors, and so there is no distension of the spiral arterioles, and the funnel shape is not formed, and then these blood vessels are actually fibrous. So they are narrow and fibrous, and hence causing damage, which is the vascular endothelial damage, and then this occurs due to the lipid metabolism, dysfunction lipid metabolism. And when there's dysfunction lipid metabolism, there's increased oxygen-free radicals in the blood. And when these are increased, they cause vascular damage. And because the vessels are actually already fibrous and they're already narrow, it causes the disease to actually progress. And then you realize that when there's endovascular damage, there are inflammatory mediators that are actually released, such as cytokines. And these cytokines can be maybe tumor necrosis factor and also interleukin-2. And these mediators actually cause further damage to the endothelial layer of the vessels. Yeah. Then immunological intolerance between the maternal and fetal tissues also will just lead to the damage of the endothelium, as well as causing the vasospasms that will lead to eclampsia or preeclampsia. Coagulation abnormalities also will cause that nitric oxide may be actually deficient. And we should realize that nitric oxide and prostaglandin I2 are synthesized in the vascular lining. And so if it's damaged, it's not going to be able to produce that. And so the nitric oxide deficiency actually leads to the vessels are not protected, and so they're exposed to the vasoconstriction, because nitric oxide relaxes the blood vessels as well as dilates them, and also prevents aggregation of platelets. And so if this is not present, it will lead to the preeclampsia that we see. And then genetic predisposition, such as the mutation of the factor 5, is just also falling under the coagulation abnormalities. We can move. Okay, I think this is most of the stuff that I've actually explained, but just to further clarify. So I was saying that when there's failure of the second trophoblastic invasion, the myometrial segment is responsive to the vasoconstrictor stimuli, which will lead to the reduction in blood flow and lead to the acute atherosclerosis of the spiral arteries, and also obliteration of the lumen once thrombi start accumulating in the vessels. And when that occurs, the platelets also have contributing to that thrombi formation, because you realize that nitric oxide is actually not present to prevent the aggregation of the platelets. And so blood flow is actually reduced about 1/3 of it due to the fibrosity as well as the narrowing of the ureteroplacental blood vessels. And so this causes actually the inflammatory proteins to be released, and also leading to the endothelial damage, which will also further cause the vasoconstriction. So when there is vasoconstriction, this vasoconstriction will not be limited just to the blood vessels there, but the entire the arterioles of the body are actually affected by the vasoconstriction. And so you see that there's reduction in the flow of blood to the kidneys, which will cause the glomerular damage. And when the glomerular is damaged, it causes oliguria, as well as proteinuria, just as we saw when we are trying to diagnose someone with preeclampsia. We're going to find that there's proteinuria yes, there's proteinuria, and oliguria also will be maybe actually a presentation that the patient will come with as they visit the hospital. And the reduction in blood flow now to the eyes will cause the blurred vision, the flashing light, and also may cause scrotoma. Yeah. And when blood flow is reduced to the liver, you find that the liver gets injured and it may swell. And when that happens, the liver enzymes are elevated, and the swelling also causes the capsule to stretch, which actually leads to epigastric pain. Yeah. And so as I earlier said, to say there's a thrombi formation in the vessels because of the massive use of the platelets, which will now, when there's thrombi formation in the blood vessels, you find that while the red blood cells are flowing through the vessels, they will get into contact with those thrombi that are formed in the vessels, and that would cause the destruction of the red blood cells. And when the red blood cells are destroyed, this is what we call hemolysis. And so